Hi, this is Larry Bauer, Chief Executive of the Family Medicine Education Consortium, and I'm pleased today to be talking with Dr. Dan McCarter, a family physician who is National Director of Primary Care Advancement for ChenMed. He's also Associate Professor of Family Medicine and the Department of Family Medicine and Associate Professor in the Public Health Sciences Department of the University of Virginia. Dr. McCarter, thanks for joining with us today.
Great, Larry. It's great being here.
Also, I'm joined by Alyssa Abel, who is a fourth-year student at Albany Medical Center. Allie, thanks for joining with us today.
For having me.
So, Dr. McCarter, can you give us a little bit of background on you? Tell us where you went to medical school and residency, and then what's happened to you over the course of your clinical career that led up to your work with ChenMed.
I went to the University of Virginia to medical school, and I stayed there to do my family medicine residency. Then I actually stayed on faculty there, full-time faculty, for 27 years. I started a rural practice out in Nelson County, Stony Creek family practice, and had one of the first EMRs in the University of Virginia system out there starting in 1990. Later, I was on the board of directors for the physician practice plan. I was the associate chief medical officer for ambulatory services at the University of Virginia for about 5 years. And after that, I was the medical director and lead executive of Virginia ACO. It was the University of Virginia's Track 1 Medicare Shared Savings Plan. Then I joined ChenMed, and about a little bit more than 2.5 years ago, I was the chief medical officer in Richmond, Virginia for 2 years. And then I switched into the national director role in May of this past year.
So tell us about ChenMed.
ChenMed, we do full risk Medicare Advantage for low and middle income seniors. We're a high touch primary care group. It started as a solo private practice 35 years ago in South Florida, Dr. James Chen and his wife Mary. And now currently we have 62 offices in 8 states, and we're adding another 20 offices and going into 2 additional states this current year.
And what is it about ChenMed? You've got a model of care that has produced some pretty substantial outcomes. Can you describe that model of care?
Absolutely. So what we do is we have PCP-led care teams that work with smaller patients. It's almost smaller groups of patients. It's a concierge model for low and middle income seniors. We cap the panels at about 400 patients. So it's a very high touch primary care for complex chronic patients. And we will get results that will about a third fewer hospital days, about a third lower cost. We can have 30% plus increased use of the maintenance medications, blood pressure, diabetic, cholesterol medicines. And we do all of this, and as you might imagine, we get very good patient satisfaction results. Our model is 1 visit a month per patient at least, or more frequently if we need that. I'm sorry, my phone keeps buzzing. I need to figure out a way to cut it off. So we do the high touch model, 1 visit a month, higher complexity. With sicker patients, we will see them more frequently. Because we're fully capitated, there's never a copay between the patient and us. So the patient doesn't pay anything additional to see us, whether they see us once a month, once a week, or every day. The cost is the same to the patient.
And can you describe your service team? What are your practices look like? How do your teams function?
So our core model is the PCP-led care team. So it's the PCP and the care promoter, either a medical assistant or an LPN. Then you'll have 3 to 4 care teams working in a center, but in addition to those 2 of their care team, they will also have a care facilitator, which is the person that helps schedule their visits, and each care facilitator will have 1 to 2 care teams, and then they'll have a care coordinator that helps make the referrals and make sure we get the records back on those patients. Then each center is managed. One of the PCPs is the medical director of center, and in addition to having his care promoter that he or she are partnered with for their care team, they're also partnered with a center manager. So they will run that center as a dyad. In addition to that, you're going to have a community case manager in each center, which is an RN that can go out and do home visits for the what we call the high-profile patients, the higher complexity patients. And there's also in each market, there's going to be 2 to 3 acute case managers that actually will follow our patients into the hospital when they get admitted to the hospital, so we're getting the information back from the hospitals. In addition to that, we offer acupuncture at our centers. We offer behavioral medicine of some sort. In some areas, it's licensed professional counselors. Some areas, it's clinical social workers. In some markets, we have a psychiatrist that works part-time seeing our patients. And then we include cardiology as part of our primary care. So each market will have 1 to 2 cardiologists that split time in the different centers because we find out 25% or more of our patients have heart failure. If you include hypertension as a cardiac diagnosis, 60 to 65% of our patients have some sort of cardiac condition.
So could you go back to the issue of you have somebody from the center follow the patients into the hospital? These days, in most primary care, the primary cares have been excluded from the hospital. So how do you handle that?
Well, we get our case managers get the credential to just do to basically visit the patients in the hospital, and then they will coordinate care with the care teams in the hospital. So they will help the hospitalists and the PCP connect to make sure that when the patient goes in the hospital, they have all the information they need. But when the patient's coming out of the hospital, to make sure nothing falls through the cracks on the way out, and that we can then get the patient in for a hospital follow-up visit. Very often will occur. We want those to occur in the first 72 hours once the patient's out of the hospital. But sometimes we'll go so far as to send an Uber to the hospital to pick the patient up to bring them to our office to see them on their way home.
Wow, I imagine that.
And
go ahead.
Yeah, well, and I was going to say, Larry, the other thing is we're changing up some of that around the current COVID situation. So, if you want to, we can talk about what we're doing around that too. I'm giving you the model as it existed 2 weeks ago, but if you want to talk about the COVID situation, we can do that later as well.
Okay, good. We'll come back to that. So how does that work with the hospitalists? Do they feel, are they receptive to having someone from your team engaged in the hospital directly with them, with the patients?
There can be a little bit resistance at first, but I think once they get to know us and understand we're there to do what the patient needs, we're not there to second guess them. but to offer information that they may not have. And as a general rule, they very much like having the primary care physician available to ask questions of, and then also to make sure they can get the follow-up when the patient is discharged from the hospital and make sure things don't fall through the cracks, because they're very often getting evaluated on their hospital readmission rate. And so
Right.
to the extent that we can help make that transition, it works well for them and works well for us too.
Boy, that's really awesome. I commend you for the vision to do that. I wish every primary care practice was able to do that. So you've got a broad team who can come in offering services like acupuncture, et cetera. What's the patient's reaction to all of this? This is a model of care that they've probably not experienced before in their lives.
Right. And I think that's exactly right. I mean, and obviously the patients who stay with us are the patients who really, really like that. I mean, it is, they feel like we treat them like part of our family, and very often they treat us like part of their family. So it is, to have somebody available. I mean, one of our doctors is always available. Each of our providers has a cell phone, and most of the time the patient's doctor will answer the phone if they call, but it's not to say that our doctors don't take time off. They do, and we encourage them to do that and take care of themselves. And when they're not available, there's always a doctor in each market on call, and so the patient always has access to a physician 24 hours a day, 7 days a week. 24 hours a day, 7 days a week, 365 days a year.
Well, that's fantastic. What else? You've been around for a while, so you've seen a lot of different models. What else do you think folks would like to know about the ChenMed model and how it works?
Well, I think having the resources in the primary care and the time to spend with the patient is just very gratifying. I think having the ability, if a patient is having difficulty getting their medications organized, that you can bring them into the office. The physician would have time to spend with them, or some of the other team members can help. Having that community case manager that can go do some teaching at home. That's not, we certainly work with home health agencies, but a lot of times people don't need a full-blown home health intervention. They need somebody to come by and make sure they're getting their medication boxes filled correctly, and they need somebody to check in on them. I think having the coordination with the other doctors and being able to run cases by. I mean, we have meetings once a week in each center where we talk about the complicated patients and the patients in the hospital and what we could do to either help them get to a lower level of care. So it's sort of like being back in a teaching environment, in that you're talking about cases, you're learning from cases. Once a month, we get all the PCPs together in the whole company, so everywhere we are in the 8 states, and we do some educational program. We've done programs on burnout, we've done programs on diet for the doctors. We will do programs on, we recently had, the most recent one was around COVID-19 and our response, and the way we were reviewing the literature and the way we were organized around it at the time, so to ask questions. The other thing we offer is a MD Help email address, so anybody in the company can send an interesting case to the MD Help, and there's a group of doctors in Miami that will either answer it or will send it out to some of our other clinicians with expertise. We've got a few endocrinologists in the company. We've got a few ID specialists. We've got a few nephrologists. And so they can send it out and get feedback on that patient from one of your colleagues on the patient without having to do necessarily the full-blown consult.
Well, and is MD Help, is that a service that's created by and organized by your company, or is that an outside organization?
No, it's all us. It's all us. You generally know who you're talking to. I mean, I wind up answering a few of those questions, and so I will always. The doctor always has my personal phone number. If they have further questions, they can call and ask.
Wow, that's fantastic. So it sounds like you've developed a very interesting culture. Could you speak to how that culture is organized? How do you create a culture where that attracts people to a ChenMed practice?
Well, Larry, that's a very interesting question. I think we're looking for people who want to pursue their purpose and fulfill personal opportunities. So we're not asking people to take a vow of poverty. I mean, because we're fully capitated and we have that 30% reduction in hospitalizations, it is a model that makes money. And so we are able to pay very competitive wages, but we also find it's generally people who really want to serve. It's not about the money. But it is for people who want to serve their fellow man and they want to work in this environment. I've heard some people say, because we're exclusively Medicare Advantage, and I've heard some people put down Medicare Advantage. They say you cherry pick Medicare Advantage, cherry picks patients. And I have to agree, we do cherry pick patients at ChenMed. We take care of the old, the poor, and the sick. And that's who we go after. And we put our practices in underserved areas specifically. So I think people who get satisfaction out of serving their fellow man, but like to do it with a robust team and that can deliver better outcomes. I think that's ideally who we're looking for.
So if you get the right people on the bus, so to speak, you get the right culture, or you get the start of the right culture, but there must be some things that you do as an organization that really helps that culture to grow and to take solid root.
Well, so absolutely. I mean, as I said, we have these regular meetings, so I think that's helpful. When I went through training, even going out and doing rotations in the community hospitals, there would be a physician's break room, and all the doctors basically met at the hospital every day. But as you pointed out earlier, very often the people who do the office work aren't in the hospital. And very often when the people are working in the office, they're so busy when they're trying to churn through 30 or more patients a day, they don't even really get to spend much time with their colleagues in the office. And so by us creating these meetings every week in the center, we have the ability to have some of that camaraderie. We also work on a regular basis to have regular social functions. We encourage people to take care of themselves. And we encourage, the care teams to get together for lunch and to have the ability to socialize, as well as it's not just the physicians, it's everybody in the center. So, I think it's our values that we work with are love, accountability, and passion. And most everybody adds on fun as a fourth value that we very much want to make. We spend more time awake at work than we do anywhere else. And so we want that to be a fun place to be. The other thing, I think we do a great job of onboarding doctors. I mean, we have people spend 2 weeks in training that has typically been done in South Florida at the corporate office. Right now, that's being converted to online, at least for the time being. And then you get another week of onboarding in the center. So it's not a matter of doing a couple of hours of the EMR training and then getting handed a full schedule. It's 3 weeks of getting oriented into the way we do things getting to work with somebody else who's already doing it. And then, that fourth week, when you start seeing patients yourself, it's still generally done at a lower schedule. So you're ramping up gradually. You're getting to know your patients as you go. One of the things we do, because we're a physician-led company, a lot of groups, a new patient means you get to bill a new patient visit to insurance. Well, we're not billing RVU based anyway, so we're not concerned about whether it's a 99213 or a 99204 or what the different E&M codes are. But what we do is because we're not worried about that, you have the time to spend with patients, and every time a patient is new to a PCP, they get 40 minutes. So a new patient is new to the PCP. It's not just new to the practice. So we give 40 minutes every time a PCP sees a patient that's new to them, so they can have the time to get to know the patient that first visit.
That's great. So let's turn now to the COVID crisis. How is that affecting your organization?
Okay.
How are you folks responding?
Well, and I'm glad you asked that. I think I think we're very fortunate. We have one of our leaders, Jason Lane, in the company, is an infectious disease specialist, and he also has quite a bit of experience responding to public health crisis. And so we started planning back in January for saying, well, what if this came to pass, what would have to happen? And then about 3 weeks ago, it was pretty clear that it was coming. And so we worked on a plan to convert our office visits, as many as possible, to telephonic and our video office visits. And the thing that works with us is because we're fully capitated, our revenue is basically baked in from last year. We don't get paid by the number of patients we see on a given day. So if we can manage them by the telephone and help keep them healthy and out of the hospital financially, it still works. We don't have to worry about the revenue shortfalls that some of the people in fee-for-service might. But we actually worked the week before last. We actually had over 50% of our visits were telephonic. Last week, we got that number up to over 80%. And this week, because we've had some exposures in a couple of markets and a couple of centers, we have some centers doing 100% telephonic work and not bringing patients in. We've got others that are, right now during this time, we're trying to hit the sweet spot between 80 and 90% for the sort of maintenance visits, the routine follow-up visits, and then the 10 to 20% that really need to be seen face-to-face. We have the centers cleaned 4 times a day. Everybody that comes in the building, staff, patient, delivery man, is screened with a temperature, asking have they had a fever, cough, or shortness of breath. And so our goal is to keep every center as safe or safer than the supermarket is. And it seems to be working well so far. So it is, the other thing we're doing is because we're not bringing the patients in as frequently. So in addition to their regular office visit, which may be a virtual office visit with the doctor, so that's happening at least once a month. Every patient is getting a call every week from one of our staff members to see how they're doing, to work on the loneliness that goes along with this social isolation. And, we may need to find that they're afraid to go out to the grocery store, and therefore we need to make arrangements with one of the local food banks to get them some food, or, they're running low on toilet paper. We certainly don't want our older patients with 5 or 6 chronic medical problems out searching Walmart for toilet paper. So we'll make arrangements to find some and get them some toilet paper. So I think it's working incredibly well. It's so far been I mean, I think we're all operating in a very fast-paced environment right now, but what we're doing right now is very controlled, and we're really concerned for the safety of our staff and the safety of our patients. And I think we've had a very good response to it so far.
Well, I want to commend you for what you have done. Ellie, I'm going to turn to you and see, as a fourth-year medical student, if you might have questions for Dr. McCarter.
So I was wondering, we've talked to a few people about their responses within their health systems to the COVID crisis. What are your thoughts on, as we get through this crisis, what are your thoughts on going back to in-person office visits, or do you think primary care is really changing to a future model during this time?
You know, and it's interesting because I've been spending a lot of time in our centers and talking to our doctors. And I can tell you the doctors like the person-to-person, face-to-face relationship. I think the thing that has allowed us to do what we've done so well is the relationship we've built with those patients over time. I don't think that for the patient population that we're taking care of, that a completely virtual relationship would work. And we haven't really discussed this. I think having access to quality primary care is, I mean, that's huge. And I think, is this another avenue to allow that access? I think it certainly can be. I think it would be. I think we will learn how to do that. I don't think we will go to. I don't think. I can tell you that our goal is not to have 90% or 80% of our visits to be by computer. It may be that we will offer this as a service. It may be that we decide that, you know, long term, maybe the right number. I'm just guessing. I have had no discussions with our company on this. So, I mean, would the right answer be 10 or 20% of our visits to be online, or is this a way to check up on our really high-risk patients more frequently? So we're seeing them once a month, but then they're getting a video check-in once a week. That may certainly be a possibility too. I think again, because of our being fully capitated, it gives us a lot more flexibility with what we're able to do there. And the patients aren't concerned because they're getting a bill for this every time we engage them virtually. So it leaves us a lot of flexibility and a lot of freedom. It will be interesting to see how it works out.
Well, that makes a lot of sense. My other question for you is, so when you graduated from residency, did you envision yourself becoming a national director of a health system like this, or how did that kind of evolve?
Yeah, you know, it's interesting. So I grew up in a small town in southwestern Virginia, and my goal had always been to go back there to practice. But there were some, but I wasn't sure exactly when I wanted to make that return. And so my plan when I finished residency was to do locum tenens for a year while I sort of figured out what my next step after that was. And this was at a time before everybody was drowning in debt. So I really didn't have any great amount of debt to worry about. And I went to the graduation. Louis Barnett, who's one of the fathers of family medicine as a specialty, was the chairman of the department. And he, at the graduation dinner in the rotunda at the University of Virginia, made a comment to me when I was, you know, getting my certificate that he hoped to get me back to Virginia someday. And then Monday, he called and offered a job to start this practice out in Nelson County. And our agreement was that I was going to do it for a year, and then I was going to go find a real job, and he was going to go find a real doctor. But I only stayed there for 27 years after that. So it was one thing. It was one thing led to another. I mean, I was very happy practicing in a rural practice. And, you know, it's just in the last 3 years since I joined ChenMed that I don't always introduce myself as a country doctor because I'm practicing in an urban area now. But I think it's been a really cool ride, but I don't know how I would have ever planned the career path that I took.
So if I can comment, Lou Barnett was one of my heroes. When I first started in medicine, I got introduced to him. I believe it was at an STFM meeting, and just very impressed with how he led and how he nurtured medical students and residents. I've heard many a story of how he touched the lives and the spirit of those who came to medical school with a deep service orientation. And I've read some of his writing, just an impressive role model.
Yeah, I would agree with you. He was just, I think everybody who trained with him, it's almost like being part of an extended family.
Right.
It truly is. And of course, I think his Sunday lunches were legendary. He and Mrs.
Yep.
Barnett would have lunch every Sunday afternoon at their house, and medical students could just call on Saturday and say they were coming, and the cost would be, they didn't have to bring anything, and then residents who wanted to come were expected to bring a dish of some sort for a covered dish, and you might be there by yourself at dinner, or you might be there with one of the legends in family medicine. I think Bob Rakel was there for lunch one Sunday, and I think Marion Stewart was there for lunch one Sunday, and you'd be there as a resident or medical student, and you weren't quite aware of who you were sitting there with. So it was actually
Right.
pretty cool. So yeah, no, I mean that was just happening to be at the right place at the right time.
That is awesome. So can you look into your crystal ball?
Sorry about all that.
No, that was fine. That was absolutely fine. Where's ChenMed
Okay.
going? What do you see over the next 3 to 5 years?
Okay, well, our goal our vision is to be America's leading primary care provider, transforming care of the neediest populations. And we want to do this by honoring seniors with affordable VIP care that delivers better health. We've been doubling about every 2.5 to 3 years, and that goes all the way back to 2011. So we're on one of those exponential curves, although I think we're on a good one rather than the COVID curve.
Right.
But so if you said 5 years, our goal would be to have 500 offices and probably have, what would that be? If we had 500 offices, that means we'll have to have about 2,000 primary care physicians working for us, and certainly be in a lot more states than we're in now. We usually say we haven't crossed the Mississippi River, although we do have one practice in New Orleans. It's on the West Bank. So I guess technically we have crossed the Mississippi River. But, I think in the next year or two, you're going to see us going further west and continuing to expand.
Well, one of the things the FMEC is hoping to do is to help you to succeed in that vision and to find those 2,000 family physicians so they can come work in a model that takes such great care of people. I just want to commend you for the vision, and maybe someday I can get to meet Dr. Chen. He's got to be a pretty remarkable individual to have, he and his wife to have created what you're sharing with us today.
Oh, yes, absolutely. I think they both, and they're both still very actively involved. And so I think that would be great. And of course, Chris, his son, is our chief executive officer, and Gordon, their other son, is our chief medical officer. Both just brilliant physicians, excellent leaders. It's a pleasure to work with them, and it's a pleasure to actually, when you're discussing business and medicine, you're talking to physicians who are putting the patients first, and it's a great environment to work in. I think we're working to grow more physician leaders. So certainly the way we're planning on expanding, we want PCPs who want to be PCPs and do PCP work, but people who are looking for leadership positions and want to learn and grow in those, we're committed to offering leadership development and leadership training along the way too. So we would absolutely like to work with you on this, Larry.
Fantastic. Well, I want to thank you very much for spending time with us today. And if there's anything that the FMEC can do in the short term or the long term that will help either the company overall or any of the practices, as you know, our service area and yours overlap significantly. So if there's some way we can be of help, please let me know. And thanks very much for talking with us.
Absolutely. Absolutely. Hope you have a great day. And Allie, I guess, do you know where you're doing residency yet, or have you decided?
No, I'm taking a gap year doing leadership training with the FMEC. So next year I'll be matching. Okay. Well, great. Well, anyway, it was a pleasure talking to you, and good luck with your leadership training as well.
Okay, take care all.
Okay, take care. Thanks, Larry. Bye.